Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. Welcome back to My Favorite Learners. Today we're talking crisis management in the OR, specifically anaphylaxis, with two powerhouses in the nurse anesthesia education community, Chrissy and Anna, CRNAs and co-founders of Confident Care Academy. Chrissy started in the CVICU at Penn, felt the gap between school and real ICU readiness, and turned that "I wish I knew this" feeling into a mission to teach. Anna's path runs from being a CNA to surgical burn tech to being an RN in Johns Hopkins CVCICU through the COVID-19 pandemic, even tents in hospital parking lots, before finishing CRNA school in 2025 and doubling down on education. Together, they're building the resource they wish they had. Today, how to spot perioperative anaphylaxis fast, why epinephrine comes first, and what to document so the next team is safer. Let's get into it. Hello, my favorite learners, and welcome back to another episode. Today, I am joined here by Chrissy and Anna, two highly experienced educators in the nurse anesthesia world. Thank you guys for being here today with me. We are discussing anaphylaxis. So I love talking about crisis management. You guys are experts on this topic as well. So thank you for being here.
Thanks for having us.
Thank you so much.
So I do like to start off the podcast by talking a little bit about how you guys ended up in CRNA education, probably RN education initially, and now into the CRNA world. So Chrissy, you want to go first and kind of talk about your journey to education?
Yeah. So I think the inspiration for Confident Care Academy and for educating nurses in general started when I was in CRNA school. I was one of those new to ICU nurses. I got straight in after doing a second degree accelerated nursing program, and I felt like I drowned as an ICU nurse. And the stakes were incredibly high. There were incredibly high expectations for us as nurses. We presented the patients during rounds. I felt like I was always so self-conscious about not having all the answers to things or not really understanding what was going on with my patients. And again, nurses were held to a very high standard on my unit, which was a good thing, but I felt like there weren't a lot of resources to help me catch up. I was very, very, very far behind, and I just didn't have a good way to catch up. There were no influencers who were teaching things on YouTube. I would read textbooks in my spare time. I would Google things furiously, and things tended to be either very patient forward, meaning way too superficial, way too simple an explanation, not really relevant to me, or way too physician forward. And they would have to do with prescribing guidelines and research studies about statistics, but not really helping me at the bedside understand what emergencies I needed to look out for or how to manage my patients. And it wasn't until I got to CRNA school that every single day that I had a pathophysiology lecture or an anesthesia lecture, I said to myself, oh my God, I wish I knew this as a nurse. I could think of a patient almost every single day that would have benefited me, or the patient would have benefited, I should say, from me having had that knowledge. And it shouldn't be exclusive to advanced practice nurses. You shouldn't have to be a CRNA to understand how to take good care of an ICU patient. So that's kind of where the vision for providing high-level, graduate-level education to bedside nurses was born. And once I sort of accidentally developed a TikTok platform, that's when I knew I could actually take that old idea and run with it. And that's how I met Anna and had her come on with me to partner. I wanted someone who was still an ICU nurse at the time to help me with my blind spots. And I was sure that things had changed since then. So she shared a similar education style and communication style to me. And I knew she would be a great partner. And I was correct. We've ran with Confident Care Academy ever since. It's been a really awesome journey.
That's awesome. I love the entire story. I also thought you two were sisters. So I think because the big sis, little sis. So you're not sisters.
No.
Not biologically, but when I'm the oldest of 6 kids, and growing up, I always asked my parents to please adopt someone else so that I could have a big sister. And I feel that I manifested that in Chrissy.
Bingo, it all worked out.
It just took 27 years, you know? But yes, we both met on TikTok in 2020, and we had similar experiences. Chrissy started off in a high acuity CVCICU. I started off in another high acuity CVCICU, and I was a new nurse during the pandemic. So after I finished orientation, I was thrown into COVID ICU nursing and really found that the resources weren't there. And it was a very stressful time to be a new critical care nurse. And found myself documenting my experiences as a nurse and then looking for community with other people who were going through similar experiences. And as I started the anesthesia journey of applying to CRNA school, going through training, found just continuation of those gaps. And I've always loved teaching. I'm the daughter of a teacher and I'm a teacher myself. Chrissy asked me to join her back in 2022, I think. So we have the big sister, little sister dynamic, and we really just believe that nurses are capable of understanding whatever they're taught. And people don't always believe that nurses are capable of understanding or should be given all of this information. And we think that nurses are very capable and we want to give them the resources that we did not have when we were in their position. And whether it's for APRNs or nurse anesthesia residents or registered nurses or nursing students, we want to give people the access to resources that we didn't have every step of the way. And we're going on like 3 years now. So it's been such a fun ride.
Expanding into our first anesthesia lecture series, which we're really
Woo!
excited about. Our anesthesia foundations course is rolling out shortly. So it's kind of cool that we've like evolved as Anna's journey has evolved and, we're capturing people across the spectrum. So we're excited about that.
Yeah, that's amazing. I was going to say how empowering because all these different from Anna's experiences to Chrissy's experience, you guys have different experiences as we all do, right? But you guys take your different things that you've gone through in nursing and now into nurse anesthesia, and you can empower those that want to become CRNAs or are in the ICU that need to have that empowerment to learn more. So I love that. All right, so let's dive in. We're going to dive in now, switching topics. We're going to talk about, again, from anaphylaxis. So I have this clinical scenario I'm going to read because as anesthesia providers, this could be us. This hasn't been me. Have you guys ever experienced intra-op anaphylaxis? Okay, so Anna, you guys can talk about your experiences maybe after this or at some point during this discussion. But so this is the clinical scenario. Okay, you're assigned to room 5, a laparoscopic appendectomy, 35-year-old woman with no known drug allergies, mild asthma as a kid. Standard monitors are on. You pre-oxygenate and induce with fentanyl, propofol, and then rocuronium. Smooth intubation. 2 minutes later, the nurse hands you 2 grams of cefazolin, or Ancef as we know it, IV. You push it or hang it as a piggyback while the surgeon is prepping. 60 to 90 seconds later, after the antibiotic finishes, the ventilator starts to alarm. Peak pressures jump from 18 to 40. The end tidal CO2 waveform narrows or becomes more shark fin-like, right? And the SpO2 drifts from 100 to 92% on 100% FiO2. Not good. None of this is good, okay? Now you're tachycardic at this point, okay? Heart rate climbs, speaking of tachycardia, the heart rate climbs from 78 to 128, yours and the patient's. The blood pressure falls from 110/70 to 65/30. You switch to manual ventilation bagging, and it feels tight with diffuse wheezes. The circulator lifts the drape and mottled flushing across the neck and wheels. This could be you. So what would you do? So I just wanted to put this clinical picture in to show the importance of knowing how this works physiologically and then what we're going to do to help this patient with this clinical picture, right? So let's start with what's really going on in the body, that physiological portion of it. So Anna or Chrissy, whichever one of you, can you kind of walk us through what's happening as this patient heads into anaphylaxis under anesthesia?
Yeah, totally.
Do you want to take it away, Anna, or either way?
Either way. Going through like very, very broad and then hand it over to Chrissy. So broad umbrella, very surface level view is that we are thinking this is an allergic reaction. We're thinking this is a type 1 hypersensitivity IgE mediated reaction. When I was a nurse anesthesia resident, I always would think E for emergency. So IgE, it's an emergency. This is an IgE mediated reaction. And then surface level continuation, we're seeing mast cell and basophil degranulation, just causing a massive histamine response, which is causing vessel dilation. We're seeing involvement of tryptase, leukotriene, and prostaglandin release. So broadly, vasodilation at the surface level. This vasodilation is leading to hypotension. We're seeing a bronchospasm. That's where it's tight as you're bagging, like you were saying, Chloe, and airway edema. I and Chrissy wrote a whole 2-hour lecture on this, so I'll hand it over to her.
Yeah, that is the exact classic representation of an IgE mediated reaction, like you said, Anna. And what's so challenging about this under anesthesia is we have two essential problems. One, if a patient's under general anesthesia, they can't tell us that they're wheezing. They might be completely covered. You might not see a skin reaction. But what's even trickier on the flip side of things is that this is a very classic picture of a patient who's been exposed multiple times to a trigger and whose allergy gets progressively worse over time. So when we think about IgE with food allergies, for example, the first time a person is exposed to a peanut, no reaction, right? The second time a person is exposed to a peanut, now their body has antibodies that are used to looking for peanuts, and now they have a reaction. The third time they see a peanut, now the reaction gets progressively more and more and more severe, right? To the point where they can't even be on an airplane with somebody opening a bag of peanuts, right? And that's when people tend to present with this exact clinical picture of the wheezing, the shortness of breath, and the skin reactions, progressing to nausea, vomiting, eventually hemodynamic compromise. In anesthesia, though, oftentimes when it's a medication-induced anaphylaxis, we actually bypass this entire process. So it doesn't always follow this exact clinical picture. Some patients on their first exposure to a medication will go straight to anaphylaxis because the complement system is actually directly activated first, instead of going through that typical IgE pathway. And when this happens, it could be someone's first exposure to a penicillin or a cephalosporin, their first exposure to a neuromuscular blocking agent, and it can go straight to hemodynamic collapse, bypassing any skin reaction or even wheezing. Sometimes those symptoms come later, and the first presenting symptom is cardiovascular collapse. And you won't understand why that is because, again, it doesn't present in that classical picture that we expect. So patients in anaphylaxis in the OR may or may not present with the urticaria, the flushing, the hives, the wheezing, the bronchospasm. They might just code. What's so scary about anaphylaxis under general anesthesia? It could really go down either pathway.
I would say that's very scary.
That is very scary. And again, like you said, patients can't tell us, right? So I think that's really that's why this topic is super important to talk about, because it's switching that mindset from the nursing bedside into the operating room where patients can't report to us what's going on. When Anna, you said you've had anaphylaxis in the OR. You want to tell us a little bit about it?
Yeah, twice. So I'll tell both stories because I think both were really excellent exposure as a nurse anesthesia resident. I had one as a CRNA recently and one as a nurse anesthesia resident. The most recent experience I had as a nurse anesthetist, it was a pretty classic presentation. So we induced and then I gave antibiotics. I do my test dose, that can be debated for a different time with the antibiotics. I would be interested to hear what both of your approaches are. But following antibiotic and induction within about 5 minutes, it was just like you were saying, Dr. Gomez, like the increased airway pressures, urticaria. We're seeing increased airway pressures, hypotension, tachycardia, whole nine yards. Or we're seeing a rash breaking out like on the trunk and on like the face. So walking down that pathway, we're like, this is likely either rocuronium or penicillin induced allergy. One of the two, who's to say, truly. It would be interesting. And then we walk down the pathway of treatment, which I know we're going to get into later inside of the podcast. But in terms of cephalosporins and antibiotics versus induction agents, Chloe, do you want to talk about which one is a little bit more common?
The non-depolarizers. Yeah, which is interesting. You would think
antibiotic. Because in nursing school, we hear like, oh, antibiotic allergy, antibiotic allergy, antibiotic allergy. And it's interesting that in anesthesia, do you want to talk a little bit more about that the induction agents in allergic reaction?
It's so interesting about this is you're right. Just like Dr. Gomez just said, the most common offending agent is your non-depolarizing neuromuscular blocker. So specifically your rocuronium, your vecuronium, and so on. I actually believe rocuronium is the most common offending agent. And then after that would follow the antibiotics as like the number 2 category and latex as the number 3 category. What's interesting about antibiotics though is you're right, Anna. We all have this picture in our brain of like antibiotics causing allergic reactions. And so many people have a penicillin allergy in their history. But the actual cross sensitivity of a person with a penicillin allergy in their history and their likelihood to have a true allergic reaction to specifically cefazolin, our most common cephalosporin that we give in the OR, almost every single patient getting a fresh skin incision gets cefazolin for antibiotics. It's far less than 1%. So, we have this kind of obsession, this fear, burned into our brains that we're going to give someone anaphylaxis from an antibiotic. We know that antibiotics are the number 2 cause of anaphylaxis. And yet at the same time, just because someone has a penicillin allergy doesn't mean that we should avoid the cefazolin. In fact, we should give it because giving alternative antibiotics can have far more high risk, side effects, problems that come down the line, sequelae. So, for example, clindamycin can put the patient at risk for C. diff. So we don't want to just give people clindamycin blindly if they don't have a true indication. It's actually much safer to give the ANSEF because their true risk of anaphylaxis is actually quite low.
I love that. And also with the rocuronium molecule, so it's a quaternary ammonium structure. So this is like a fun fact, I guess, and like one of my favorite facts about this topic, I guess, is that this is also found in household products and preservatives. So this kind of explains that, like Chrissy was saying, with that first exposure, some things we've already been exposed to and we didn't really know it. So then we get into the operating room and we're exposed to it again. And yes, it's the first time we've received rocuronium, but have we been exposed to molecules of that same caliber? And now this is, an anaphylaxis situation. Like, even if you're cleaning around the house and you break out in a rash, you don't really think much about it. And now you're in the operating room in anaphylaxis. So I believe that's more of a boards type question. So we'll highlight that.
I love that. And similar concept is true of opioids as well. Sometimes we get that mast cell activation because we've been exposed to similar substances with similar molecules. So that's when we go down that very classic IgE pathway that we spoke about.
Quickly, it looks like there's a couple of other types of allergens in the operating room. We see, just like Chrissy was saying, opioids, hypnotics rarely can happen. Colloids, dyes, we give a lot of dye exposure whenever we're doing imaging in the operating room. Antiseptics, NSAIDs as well. We actually are seeing some true allergies to NSAIDs, especially as people in the United States are over the counter, which for our friends who are abroad, they find that kind of interesting that you can just walk in and get like 1,000 pills of ibuprofen, Tylenol. It's interesting. And then local anesthetics as well. We do see a rare true allergy, and this is another boards related component. Often the allergy is not to the local anesthetic itself, but more to like the preservatives and the binding. So you rarely are going to have like exclusive allergy to a local anesthetic. You can often take the opposite class. So if you're allergic to ester, you can take the other class. Anyway, moving on to the next thing. So back to our clinical scenario, right?
Yeah, back to the clinical scenario. So either of you guys can answer this, but we're going to kind of walk through. The blood pressure's low, the heart rate's high. We've seen some hives plus or minus, like Chrissy was saying. So walk us through the step-by-step on what we should do at this point for this patient.
Immediately, first step, stop the trigger if you can identify what it is. So if you're halfway through giving an antibiotic, giving your antibiotic slowly, for example, stop giving it. If you're not sure if it was your antibiotic or your rocuronium, don't give any more rocuronium, even if they have twitches back. Notify the surgeon right away. We should not proceed with surgery if we have not yet made incision, right? We need to address the patient first. We need to call for help. These patients, even if they don't initially present with bronchospasm, they ultimately likely will develop it at some point during this cascade of events. So 100% oxygen. We should switch to Tiva if we can, because if the bronchospasm is severe enough, it could be difficult to adequately anesthetize them if they're not getting enough tidal volumes in and out, because once we have severe enough bronchospasm, we can't exhale adequately. We will have rising airway pressures. We won't get adequate exchange. And we should start administering epinephrine. Epinephrine is our ultimate final treatment down the pathway. But epinephrine ideally should be given intramuscularly, which is kind of counterintuitive for us in the OR. Usually we have IV at our disposal. We want to give epinephrine IV, but it's very, very, very easy to kind of overshoot and give too much epinephrine. We can increase risk of arrhythmias that way. We can increase risk of creating hypertension if we're giving too large of doses. IM is the preferred route. If you are going to give it IV, then we should dilute it out and give just 10 micrograms at a time or start an epinephrine infusion. We should not be giving large bolus doses every 5 minutes of like a milligram of epi IV, for example.
Totally.
Did you give epi in your scenario, Anna?
We did.
Okay.
And we gave it IM. I did see, actually, I think I've seen 3 allergic reactions in my short anesthesia career. One time I saw they did not dilute the epi, and then we overshot and had like pretty profound severe tachycardia and hypertension. I have a note here about epi being the be all end all in terms of treatment. And for the nurse anesthesia residents out there who are getting pimped, you probably will be asked questions about this in the operating room. The reason that it's a be-all, end-all treatment is that it stops and interrupts the mast cell degranulation and reverses all of these sequelae and symptoms that we're seeing. So it actively like stops the mast cell degranulation in its tracks, which is why we reach for that first as a first line. Yeah, it's very interesting. You often don't think if you have IV access to go and give IM for epi.
No, I love that. That's a great clinical pearl for sure. In terms of the pharmacology, I'll kind of do a brief overview and then we'll dive into each of the medications in and of itself. So we said that epi is the first line treatment for this. IM preferably, or boluses, 10 to 100 mics depending, for moderate symptoms, and then, 100, 200 for more severe symptoms. And then we kind of go into the refractory. So if the epi is not working or we're not seeing that increase in blood pressure and stabilization hemodynamically, we can move towards vasopressin and methylene blue. If you're giving methylene blue for this is a very bad day. Like, I would like to go home sick. Like, this is not a day I would like to continue. And then after that, H1 blockers, H2 blockers, and our steroids. So we're going to kind of go through each of these medications one by one. So Anna, you kind of already talked about epi. Is there anything else you want to add about epi?
Yeah, totally. So in addition to stopping the degranulation of the mast cells, which is going to stop all of the sequelae of life-threatening symptoms, it is like the medication. It is the drug. And again, for aspiring nurse anesthetists, you should know the cellular level mechanism of action of epinephrine. It is our alpha 1, beta 1, and beta 2 medication. It's the big gun. So for your alpha 1 agonist properties, you're going to see an increase in your SV, and you're going to see a decrease in that edema at the vascular level. For your beta 1 effects, you're going to see an increase in cardiac output, an increase in inotropy, right? And then for your beta 2, you're going to see a bronchodilatory effect. So bronchodilation and then stabilizing of those mast cells. So that really targets those three components of this allergic reaction that are very dangerous for the patients. So you kind of fix with the constriction, you open up the lungs with bronchodilation, and you increase forward flow with that inotropy and chronotropy. Chrissy, I know we have a lot of other interventions. I'll give it over to you.
Yeah, we could just briefly go over histamine blockers. So whenever I think about an antihistamine, I think about Benadryl, right? Diphenhydramine. That's something that we're all familiar with taking in our household. More recent generations of antihistamines actually can also be used in anaphylaxis as well. So even like your Zyrtec, for example, is becoming more common to use for anaphylaxis in emergency departments, for example. But we don't have that IV in the OR. So for now, we are sticking with diphenhydramine. And what does an antihistamine do? Classically, blocks H1, blocks further histamine release. Believe it or not, there's actually 4 types of histamine receptors in the body. There's H1, H2, H3, and H4. H1 and H2 are the most important for this discussion today, but believe it or not, there's actually 4. H2 has to do with our gastric acid secretion. So when patients are experiencing anaphylaxis, they have increased gastric acid secretion. And it is really important that we also block H2 because we don't want this to cause peptic ulcer disease later, especially if we block H1 and then we don't block H2, they can continue to have that ongoing gastric acid secretion even after like the symptoms of anaphylaxis have resolved and people can develop an ulcer from this experience. So we want to give them famotidine, for example. 20 milligrams IV would be the dose of that. And for your Benadryl or diphenhydramine to be 25 to 50 milligrams IV. If you're having anaphylaxis, I'm giving 50. All 50.
Yeah, we're not worried at that point about sedation. So I'll talk about the corticosteroids. I feel like I say words so weird, but I say corticosteroids, so that's what I said. These basically help prevent delayed or biphasic reactions. So not life-saving in the moment again, but they reduce that rebound inflammation. So their main mechanism of action is a genomic decrease in cytokines / COX-2, a non-genomic membrane stabilization at high doses. So that's their main mechanism of action. And I'm going to kind of break it down a little bit simpler with an analogy because I'm an analogy girly and that's how I learned. The dosing for this would be methylprednisone 125 milligrams IV or hydrocortisone 200 milligrams. I've seen 100 as well, more commonly, but this resource said 200. So again, its role is to attenuate late phase or biphasic symptoms, not the first line for hemodynamic stability for sure. And I think a lot of us in the ICU, if you're listening, have given this for various other reasons. But essentially, this is the body's anti-inflammatory brake system. So it kind of mimics cortisol, a natural hormone made by our adrenal glands. Like that's just the simplest way to put it. The corticosteroids are synthetic versions of cortisol, like I said, which in the body, it has a natural glucocorticoid. It is the body's natural glucocorticoid made by the adrenal cortex. So once it's inside the cell, it goes to the nucleus and it turns down the genes that make inflammatory chemicals. And these inflammatory chemicals are, your prostaglandins, your leukotrienes, histamines, and cytokines. And they also turn up genes that make anti-inflammatory protein. So that's a lot of words, but essentially they cause anti-inflammatory properties later down the road or prevent that inflammatory system later on. So less swelling, redness, that allergic response tones down the allergic response, stabilizes blood vessels and cell membranes, and lower immune activity. So they calm the immune system, totally basic, and stop inflammation at its source at the DNA level. So that's a lot of words, but that's how corticosteroids work at the cellular level.
One thing I didn't realize about the importance of giving corticosteroids is when I was digging into anaphylaxis to write that lecture that we have at Confident Care Academy, it turns out that the biphasic response can happen on average about 11 hours later. And for food-related IgE-mediated events, it's much less likely to see that biphasic reaction. So if you're a patient who comes into the ER with a peanut allergy, we are no longer keeping most patients for 24 hours for monitoring. However, if it's a medication-induced allergy, risk of a biphasic reaction is significantly higher. So these patients should be admitted if they were not planning to be admitted, and they should be monitored for at least 24 hours because the biphasic response could be anywhere from 5 to 17 hours later, with like that median being around hour 11. So, and again, medication-induced allergies being much more likely. So that intra-op anaphylaxis does have a little bit of a unique picture to food allergies.
I think that's a really important note, especially for anesthesia learners to be aware of. If you're involved in the decision-making tree to admit a patient and not admit a patient, to be aware that a patient who has an allergic reaction to rocuronium may have a biphasic reaction 17 hours later. God forbid you sent that patient home, right? So that's an important differential to be considering in terms of monitoring. I'll also add, it's important to work these patients up and refer them to allergy to identify the trigger specifically and to add documentation in the chart to prevent another crisis. Usually if you're using Epic, if you're blessed enough to be using Epic where you're working, you can add a note yourself about the allergic reaction that you witnessed, similar to how you add a note about difficult airway. And that's something that will then automatically populate on the chart moving forward. As an educator, Dr. Gomez, do you have other things to add too?
As an educator, but also as a clinician, I feel like something that we can always do better in our practice, in nurse anesthesia practice, is documentation and alerting this system to, so this patient can prevent problems in the future for future clinicians. People make fun of me because my airway note, when I do an airway note at the bottom, I'm like, okay, I do recommendations, for airway management where I'm like, this worked and I got the airway. However, what would have worked a lot better is, ramp, bougie, glide scope. Like that would have been, I wish I would have done it differently. And this is the way I would have. And whether or not the clinician takes my recommendation or not, at least they have a guideline for, what I wish I would have had or what I wish I would have done. So this is one of those clinical scenarios where we can't just move on with our day. We need to do adequate documentation, add it to the allergy list. We all know the allergy list has had epinephrine on it before. It has had other medications that instead of educating your patient on, okay, this is a side effect, this is not an actual allergy. So we definitely need to be adding these types of things to our patients' records.
I like that you made that very good point about being really thorough in your patient education. And I also like to put that explanation in my allergy list as well. When I had an allergic reaction in the OR recently, it was to Zofran, which I've never heard of before or seen before, but this patient had ondansetron and a few minutes later developed urticaria and increased peak airway pressures and wheezing. And I was like, interesting. So, what did we do? We treated it with Benadryl. And I was about to wake up the patient from surgery. So I was a little unsure of what to do. Sat there for a few minutes and watched to see if it would resolve before we went any further. Thankfully, she was hemodynamically stable. And it seemed like a mild enough reaction where it did resolve with just the Benadryl. And so we did extubate her, wake her up, bring her to PACU, do extended monitoring. But when I documented the Zofran allergy in the chart, I explained the exact signs and symptoms, exactly what we did, and recommendation to follow up with allergy testing, because that is a very uncommon medication. And maybe it was from something else. Maybe it wasn't from me. Maybe it was from something that was in the local mixture that the surgeon gave, right? Like I can't definitively say it was Zofran. So having her go home with a note to bring to her allergist describing what happened will be helpful for guiding future care. Just like your airway notes, right? Like, hey, this is what I did, but this is what really also should happen next time. I think is really important that we recognize that our chart is communicating with our patients and future clinicians.
Yeah, patient education gives them empowerment. Again, we talked about empowerment at the beginning of this podcast, and we can empower our patients to be their own advocate because we're not going to be with them next time they come to the OR, but they will be there for themselves and they can speak to what someone has educated them on. And if we didn't, then, it does a disservice to our patients. So I love those points.
I was just going to add, I think it's helpful, Chrissy, that you brought up that it wasn't always extremely black and white as well. Like there's a bit of a range in terms of these anaphylaxis and allergic reactions. And then there's even question about what medication it was. Document and then communicate with your team and then give the patient the education so that they can be aware of what happened moving forward. And then also just looping in the other people who are around us, because sometimes an anaphylaxis results in bronchospasm and airway and then hemodynamic instability, and sometimes it's a little bit of a rash. And so for the learners out there who maybe haven't seen this before, it can present somewhat on a spectrum. And I think that that's something for people who are new to the operating room that can be confusing too. You might doubt yourself, like, oh, is this truly an allergic reaction? There's a little bit of a rash, but like my airway pressures are fine. So still communicate with your educators at that point. Like, I think this is still a little bit of allergic reaction. And then like you were saying, Dr. Gomez, like you write a note about it, you communicate. So there is a bit of a spectrum all the way from a little bit of a rash to I can't really ventilate. So it could be a whole range of reactions. But
And I love that. I would do a differential diagnosis podcast with every podcast I've done on crisis management. I've said this, like maybe we can figure out how to do it live, maybe with like all of us, but doing a differential, because it is all about differential diagnosis. And, you see high peak airway pressures. Is this this patient had a history of asthma in the past, in childhood? So you're thinking about, their pathophysiology and anatomy from childhood and what they have going on in their smooth muscle of their lungs baseline. And now you've given a medication that could have caused anaphylaxis. So going through differential diagnosis is super important in anesthesia, and treating the patient as soon as possible and kind of getting down to the bottom of it or narrowing it down is really important. I think it was the MH lecture where I saw MH in the OR and it was a lot of differential diagnosis because it's so rare.
I was just going to say real quick, like one thing that we should do whenever we suspect anaphylaxis is to draw a tryptase level. That way, even though in the moment we're not going to get that result right away, it will confirm later on whether that was anaphylaxis or not. Because you're right, sometimes it is hard to get a differential diagnosis, especially if this patient does go straight to complement activation. They don't go down that traditional IgE-mediated pathway. Their first symptom is hemodynamic collapse. Why did this patient code after induction? Was it because they had an MI? Was it because I guess that would probably be the most common differential diagnosis for it. But yeah, like, did they have an MI or was it anaphylaxis? Why would they just randomly code after I give rocuronium, right? Why else would that happen? Is it a massive ischemic event? Did they just throw a massive clot? Like, what's happening here, right? So, you don't want to start giving fluids aggressively to a patient who has just gone into a sudden heart failure that you weren't expecting, but you would want to do that if they were in a distributive shock from anaphylaxis, right? So it's really important for us to figure out these differentials very quickly. Keep in mind that hemodynamic collapse could in fact be anaphylaxis's first presenting sign and symptom when it's medication induced under general anesthesia. And again, figuring out how to rule out those differentials quickly because the management might be quite different.
That's a great point.
So true. So I feel like we could talk forever because I just love you too. And all your knowledge is so inspiring. But let's do a top takeaway from each of you on the topic of anaphylaxis.
All right. Top takeaway, epinephrine is the medication. Everything else is supportive. Epi, epi, epi.
I think my top takeaway would just be early recognition. The faster that you think about anaphylaxis, the faster you're going to be able to save a life. Don't be afraid to assume it's anaphylaxis just because there's not a rash there.
Love that. So true. Lastly, I force all of my guests to give one piece of advice or encouragement to an anesthesia learner in the throes of their academic journey. So, Anna, you want to go first again?
Yes, as a recent learner myself, it's legal to be new. It's legal to not know things. Just communicate and try to get your educators and your teammates on your side. The more you communicate and the more you loop them into what you're thinking and what your questions are, the more you can be on the same team as your preceptor and people who you're working with. Nobody expects for you to know everything. They just want to know that you are showing up prepared. So it's legal to be new. It's totally fine. Nobody expects you to get the skills like right away, but just communicate, communicate, communicate.
I see a collab merch opportunity. It's
Yeah.
legal to be new.
Legal
So
to be new. Okay. It's a merch.
I love it.
Chrissy, what's your piece of advice?
I would say don't lose your natural curiosity. I think that sometimes in school we get so focused on performance based metrics and like, did I get my information or not? Did I get to check it off and type it or not? Did I get an A or did I get an A minus? Right? We get so focused on like scores and metrics and competition that we lose our natural curiosity that drives us to actually truly understand instead of memorize. And that's what's important to take forward in your practice and to become a good CRNA, right? You can pass your boards on the first try. You can get the highest score on the C. You can have the best grades in your class. It doesn't make you a better clinician because the only thing that's going to help you put together the entire clinical picture is that drive and thirst for knowledge and that natural curiosity. So nurture that above all else. Ask why about every single thing we say in class. Question it. Everything you're reading, question it. Go on rabbit holes. Go on deep dives. Go listen to this podcast, Core Anesthesia, Confident Care Academy. DM us on Instagram. Ask your preceptors, like engage people in conversation because you're so genuinely nosy that you need to know it all. Because there's a human on the other end that's really depending on you to be that way. And I really encourage you to just like tap into that inner nerdy self and really, connect with it.
Understand why.
Why?
I love that. It's so true. And now as an educator, like on the academic side, you remember what it's like to be a nurse anesthesia resident, and want those A's, want 100%, want every intubation, and comparing yourself to your classmates. I always say comparison is the thief of joy, right? Which is like freaking so true in anesthesia school. But I had a person in class the other day, a student, I should say, person in class, a student that made a connection. And I'm going to tell you guys, because it was like the most intuitive question. And they said, because we're learning about PKA and pH, right, which is a very complex topic, and ion trapping with pregnant women and, the fetus and the lidocaine getting trapped potentially. And he said, if it's ionized, once it gets into that acidic fetal tissue, how is it making any impact on the fetus if it's now ionized, right? Like, how is it now penetrating membranes once it's in the fetal tissue? And I was like, what an intuitive question. And, I had to look it up, right? And I'm like, okay, because nothing's 100%, right? So just because we say it's trapped and it's ionized now, it's not 100% ionized. So it can still cause those CNS effects, or not really in a fetus, but a bradycardia rather in the fetus and fetal distress. But, you're making connections and those neurons are firing, and it's really important to be curious and, to house a space for learners to ask those questions and not feel stupid, which I feel like you guys do in Confident Care Academy, and I'm assuming is one of your core values, as is mine. So I appreciate your time so much. I had a couple people submit questions for you guys. I'm gonna let you guys answer these. Let me pull some
Love
up right
questions.
here. Right? More questions, more curiosity. This is a good one. So, what do you wish you would have worried about less as an rRNA? Metrics is Chrissy's. She already spoke to that.
Yeah. Finances, honestly. I think we have a lot of work to do in terms of improving the educational experience for our learners. They work full time the last 2 years of their training. And I don't think many programs offer enough in terms of financial support for people who are dedicating 3 years of their life to learning how to provide anesthesia. I just did a talk at the Illinois Association of Nurse Anesthetists about the amount of student aid and student loans that trainees get to live on. In some instances, it's about 130% of the federal poverty line. And then our trainees are on Medicaid often throughout their training. So I think we need to do more in terms of financial support for our trainees, because it really, Maslow's hierarchy of needs, right? Like, we're all very much perfectionists. We want to do our best, but it's difficult to do that if we are worried about paying rent and like having enough food. There's a fair amount of surveys that have gone out about food insecurity for nurse anesthesia residents and people taking food home from the hospitals because money is that tight. So I hope that we can take care of people's physical and material needs as they are going through their doctorate training in nurse anesthesia.
Yeah, that's a great point, and I hope that there becomes more recent from people like us speaking about it, right? So
Totally.
thanks for bringing it up. I appreciate that.
There's a big lack of awareness in the education community about like the student loan system and
Right.
what's available now. Anyway, Anna just gave a whole talk on that. But I think for me, actually, believe it or not, it was never the metrics. I actually was never a metrics girl, and I never cared that I didn't get a good grade. If I had to choose between preparing for clinical the next day or getting an A on my test, I always chose my patient. Why? Because I'm an anxious, crippling people pleaser. And that is actually what I struggled with.
Same.
Yeah.
That's like that. Yeah, I am. But, and also I do think that's a good value to have in that particular scenario. However, because I'm an anxious, crippling people pleaser at heart, I think that took away a lot of my joy from my learning experience and inhibited my ability to learn in clinical sometimes because I'd be so worried about what my preceptors thought about me that I would almost be like frozen when they asked me questions. Even though I knew the answers, I would sometimes struggle to articulate right away because I'd be so worried about guessing what they wanted me to say instead of just saying what I knew. And and performing skills. Like, oh, if I don't get this skill, then they won't let me do XYZ skills or they're going to think I'm incompetent. I was so worried about others' perceptions of me that I got in my own way as a learner. And I think that was partly because I was very young at the time. I think that's maturity that comes with age. But it is a very big reality for a lot of people in the operating room. A lot of us nurses tend to be very similar, and it can inhibit your learning and your experience and make clinical more stressful than it needs to be. So that is something I regret was focusing too much on others' opinions of me rather than taking pride in how well I had actually prepared.
I love that. I feel like I was also young throughout my journey. And I know a lot of, if you guys follow me on social media, my mom was the opposite. She was one of the oldest in her cohort. So it was very interesting to like just talk with her about, the difference in experiences that we had, because I did have a lot of that. What do they think of me? Like they think I don't deserve to be here. And my mom had the opposite where she's like, she was top dog and now she's, being spoken to in a certain way, just the different dynamics. So I appreciate you bringing that up because if you're listening and you're one of the youngest in your cohort, you earned your seat. Ask questions. Don't be worried about the perception of what others are thinking of you. Just focus on you. I think that's really important, Chrissy. Thanks for bringing it up. Let's do another question. We'll do one more, even though there were a few like really good ones. We'll do two more. Two more. Okay. This one says, how do you navigate social media while in school and standing out as a CRNA educator? So I'll let Anna speak to the social media in school because I'm old and there wasn't really that much social media.
Together.
So
Chrissy can speak part.
as far as in relation to during training, I have two kind of takeaways from it. The first is really going to come down to the culture and support of your faculty. If your faculty believe that they are raising the next generation of leaders in the nurse anesthesia profession, they will embrace social media. If you have faculty that is not evidence based and is operating from a bit of more of an old school mindset, you're going to see that in relation to the way that they teach anesthesia. They're also going to see that in relation to the way that they adopt to new technologies, innovations, and just social media in general. I was very fortunate to have faculty that was embracing technology in terms of Simvana and simulation for anesthesia education. That was also their approach in relation to social media as well. I will say that as somebody who went through training with a fairly public profile in the anesthesia profession, I took a couple of steps to protect identity. I used Delete Me so that people couldn't find my address throughout training. And then it's really just going to come down to how supportive your faculty is. My faculty always supported me advocating for the anesthesia profession and for my values and morals and beliefs. So I felt pretty supported throughout my anesthesia training. That doesn't mean that it didn't come without like adversities. I think that just going through training, you're in a vulnerable position because you are at the mercy of your faculty. You also take out hundreds of thousands of dollars in debt. So there can be just that balance to strike in terms of making sure that you are representing yourself truly, but also protecting yourself, your physical safety, and your investment. So take all of that into consideration as you're going through training. It's okay to be a leader in the profession. It's okay to advocate for yourself, for your patients, and for your values, morals, and beliefs. And then also just know that school doesn't last forever. And if there is like a period of time where you need to focus exclusively on you, then that's okay too. But things are changing rapidly. And like people are adopting social media. People do see it as a tool to advance the profession. And a large way that we are able to advocate for the profession is by talking about who we are and what we do for our patients. And that is a massive tool that we can utilize to advance the goals of the nurse anesthesia profession. So if you're somebody who wants to do social media, I say that do it. And also just, be aware of steps that you need to take care of yourself lightly. What was the second part of the question? Social media, and then
It was being a CRNA educator. So, Chrissy, if you want to speak
yeah,
to how
there you
you've
go.
navigated it, that was a great answer, Anna. I appreciate that, and I know that the listeners will too.
So the question was about being a CRNA educator on social media. Was that the question?
It was about how to navigate standing out as a CRNA educator.
I see. So that's interesting, actually, because whenever you are in a public platform and you're on public display, whether it's as an educator or a learner or just a clinician, not just a clinician, as a
Worker.
clinician, there will always be the way that algorithms work is that it's going to send your content to people who are in your area, who are in your phone contacts, who are in your Facebook friends network. All of these things will send your TikTok and Instagram videos out to people who are very, very, very related to you, people who have similar interests, which are probably your coworkers, who are probably your students, who are probably your program directors, right? You are not only extremely public, you are extremely directed your content right at the people who you're going to interact with on a day-to-day basis in real life. So for me, when I went and I guest lectured at Hunter College this week, half the people in the class had just watched me teach in person at NYSAN, the New York State Association of Nurse Anesthetists, and about a quarter of them had already followed me on social media, right? All of that content is being so driven to these people. So being aware of the way that you teach and holding yourself to a higher standard of, I always want to be extremely precise. I never want to just talk off the top of my head about clinical concepts that somebody might use incorrectly in the operating room, right? If it's something that I'm not fresh on, if it's not my true expertise, I will always double check myself before posting because God forbid somebody uses my social media and a negative patient outcome happens as a result of some incorrect information that I've shared. Having disclaimers like this is education, not advice, so that patients don't take it out of context the wrong way. Those things are really important when you're an educator online. And as far as standing out, I think the best way to stand out is just to be yourself. Truthfully, people really respond to warmth and sincerity and authenticity, even if they don't always agree with, your takes on everything. People like that you're real and that you feel like a real person, that you feel like a mentor, not just a robot on the screen. Anybody can just yap at you and recite things off a textbook, but people want to feel like you're a human on the other side. So that's kind of a twofold answer.
I love that. And I just want to say that in watching both of your guys' journeys online personally, it takes a lot of courage to do this. And, posting everything that you guys post is, I know I've been the topic of many group chats. Okay. Whether positive or negative, and I'd like to say it's overwhelmingly positive, right? And yeah, you'll have naysayers or this and that, but the overarching goal for me, and I know for you guys, is to empower learners, is to have a safe space for learners to ask questions or receive content that is accurate. We are definitely those people pleaser type A personalities where we're triple checking every fact we post, like Chrissy said. But overall, I just want to say thank you for your courage to do what you do online, because I know it has been the subject of ridicule and it's not easy and we could quit. But at the end of the day, we want to empower students. We want to empower patients to know who's taking care of them as nurse anesthetists and for learners to have a safe space. So thank you guys for doing what you do.
Right back at
Thank
you.
you so
Thank you for
much.
doing what you do. I especially appreciate how nurturing you are for learners. I think that your entire platform is aiming to make learners feel safe. And I think that that's really important in today's day and age. So we appreciate
And
you too.
I think that it comes from a place of feeling unsafe as a student. Don't you agree? Like our platforms have come from a spot of feeling unsafe. So I appreciate your comment. We're like, no, you're the best. No, you're the best. But I think it's so important to take our experiences and make the world a better place, in
100%.
any way that we can. And, again, if I'm the subject of group chats or people want to say this or that, go for it. I'm going to keep rolling with it. And I hope you guys do too.
Well, all press is good press, right? So great.
Says haters make me famous. Haters make me famous. Another t-shirt opportunity.
So whenever we have a new learner come through who is coming up in the anesthesia space and is coming up in the social media space and they have their first experience on Reddit, we tell them that you really haven't made it in the anesthesia community until there's snark pages dedicated to you on the internet. So just keep going and keep making the world a better place, keep nurturing people, keep providing education. And you know what? You make waves sometimes, and that's okay.
It's okay. Change happens that way, right? Positive change. So I appreciate your guys' time. Thank you. I'm going to plug Confident Care Academy again. Check them out in any way. Check Chrissy out on Chrissy. You want to do your handle? What's your handle?
It's Chrissy CRNA, CHRISSY.
CRNA. TikTok, Instagram, Anna.
Anna J, ANNA J, CRNA, everywhere.
Yay. And then obviously we're my favorite learners. So thank you guys for your time. We appreciate you. Leave any comments, follow, subscribe, all the things for our podcast. So thanks, guys.
Thank you.
Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.